Hello students, this is the lecture for Oral Pharmacology, Chapter 2, Fundamentals of Drug Action. The main routes of administration for drugs is enteral, parenteral, and topical. The enteral route involves the digestive tract. The oral route is the most common, but has the disadvantage of unpredictable absorption and poor patient compliance with dosing. The sublingual route is used for nitroglycerin, and the rectal route is commonly used for antiemetics, since the oral route would cause the medication to come up with the vomit. The parenteral route involves the use of a needle. The most common parenteral routes in dentistry are the intravenous, which is an injection directly into the vein, and the subcutaneous, which is used for local anesthesia as well as for insulin. Figure 2-1 shows the insertion of the needle and the location of the deposition of the drug, as well as the needle angulation for intramuscular, subcutaneous, intravenous, and intradermal applications. The topical route includes transdermal, subgingival, epicutaneous, and inhalation. Topical dental anesthetics are applied through the epicutaneous route, and controlled release antimicrobials such as Atrodox, Arestin, Periochip, and Orachix are delivered through the subgingival route. As we learned last week, pharmacokinetics involves how a drug gets to the site of action, what the body does to the drug, how the drug moves through the body. Pharmacokinetics involves absorption, distribution, metabolism, which is also known as biotransformation, and elimination. These are referred to as ADME. Pharmacokinetics has to do with how the drug is absorbed, routed to the target tissue, changed by the body, and removed from the body. Pharmacodynamics has to do with the effect that the drug has on the target tissue when it binds to the receptors in the tissue cells. The pharmaceutical effect of a drug includes both the therapeutic or intended beneficial effect plus any undesirable adverse effects. Drugs are absorbed into, metabolized in, and eliminated from the plasma. However, their effect occurs in the target tissues. The two-compartment model shows that drugs can reside in tissue or the surrounding blood plasma. As long as the plasma concentration remains high, the drug can move into and out of tissues. This action prolongs the duration of activity of the drug. The cell membrane is a double layer of phospholipid molecules with a highly polar head oriented outward and the nonpolar chains of fatty acids inside the membrane. Embedded in the membrane are proteins that include ion channels for transport of water-soluble drugs. See Figure 2.3 for more information. The types of cell membranes in the body include the intestinal mucosa blood barrier, the oral mucosa blood barrier, blood tissue barrier, placental barrier, and blood-brain barrier. The process of absorption can happen in several different ways. The most common is passive diffusion, where the drug flows from an area of higher concentration through the cell membrane to an area of lower concentration. This method does not require any energy expenditure. Facilitated diffusion uses carrier proteins that change shape and allow the drug to pass through. Active transport requires energy from ATP. Absorption is affected by several factors. The greater the blood flow to an organ, the greater the amount of drug uptake or absorption that happens in that organ. Also, the greater the lipid solubility of the drug, the greater the amount of the drug that can pass through the membrane. The salt form of the drug also affects absorption, and food and other drugs can also be a factor. pH is the acid-base balance of a substance. The pH of the stomach is 2, which is acid. The pH of blood and tissues is neutral, or 7.4. In the intestines, the pH is 6 to 7, which is basic. Inflamed tissue, due to infection, is acidic in the area of pH 5 to 6. The pKa is called the dissociation constant and is the pH that produces 50% ionized and 50% non-ionized molecules of the substance. Ionized drugs have an electrical charge, are water-soluble, and do not easily pass through cell membranes. Non-ionized drugs are uncharged, lipid-soluble, and pass more easily through cell membranes. So when pH equals pKa, half the drug can pass through the membrane and half the drug remains in the blood. Local anesthetics are weak bases. When pH equals pKa, there is a greater amount of non-ionized drug, which results in quicker onset. How much of a drug is absorbed from the gut into the bloodstream depends upon the pH, pKa, and fat solubility of the drug. Because cell membranes are composed of 2 phospholipid layers that face each other, with the hydrophilic or water-loving head facing the blood, plasma, and the cytoplasm, the hydrophobic tails face each other. The hydrophobic tails are made of fatty acids, which are basically lipids. Therefore, any drug that is fat soluble, that is lipid soluble or lipophilic, can pass through cell membranes more easily. See figure 2-4, which shows the absorption of a drug through cell membranes into the bloodstream or systemic circulation. As you can see, the drug has to go through many tissue-blood barriers to get to the final site of action. Table 2-2 shows examples of weak acids and weak bases. Local anesthetics are weak bases. Drugs that are weak acids will be mostly non-iodized at the acidic pH of the stomach, allowing them to be readily absorbed. In theory, weak acids are more readily absorbed from the stomach than weak bases. Figure 2-5 shows the effect of pH on drug absorption. In the top diagram, a weak acid such as aspirin is in a non-ionized form in the acidic environment of the stomach, and so absorption occurs. In the small intestine, which is a basic environment, the aspirin is mostly in an ionized form and absorption is prevented. Drugs that are weak bases will be more non-ionized at the pH of the basic small intestine and ionized in the stomach. The non-ionized portion of the drug shows great lipid solubility and therefore greater absorption in the small intestine. Regardless of the pH and ionization, however, most drug absorption occurs in the small intestine because it has the greatest surface area. As we covered before, local anesthetics are weak bases. The closer the pKa of a local anesthetic is to the local tissue pH, in other words neutral, the more non-ionized, uncharged the drug is, and the faster it will be absorbed with a quicker onset of action. Lidocaine with a pKa of 7.9 has a faster onset of action than bupivacaine, which has a pKa of 8.1. If the tissue pH is neutral, the anesthetic will be uncharged and therefore lipid soluble, so it will be able to penetrate the membrane and cause anesthesia. If the tissue is acidic, as occurs when there is an infection, the anesthetic will not be effective in crossing the membrane and the patient may not get numb. Drugs that exhibit extensive first-pass metabolism and have low bioavailability include morphine, lidocaine used for antiarrhythmia, cardiac antiarrhythmia, and nitroglycerin. If the drug is partially biotransformed, it goes into the general circulation and is then distributed to the target organ. In other words, oral drugs go through the intestinal tract, and when it hits the liver, some or a lot of the drug can be biotransformed and eliminated before it has had a chance to reach the target organ. Table 2-3 shows a summary of drug action for common routes of administration. Figure 2-6 shows movement of a drug through the body. Figure 2-7 illustrates first-pass metabolism. Parenterally administered drugs bypass the liver and therefore they bypass the first-pass effect. IV drugs are directly injected into the bloodstream. Summary of drug action for intravenous drugs is shown in Table 2-3. Topical dental anesthetics are placed on the mucous membranes and absorbed through the oral epithelium. Drugs placed into the gingival crevice, such as Atrodox and Arestin, are absorbed through the sulcular epithelium. Once a drug is absorbed from the GI tract into the bloodstream, it is distributed or transferred throughout the body fluids to the tissues and organs. Distribution may be restricted to the extracellular space, or it may pass through into the cells in the intracellular space. A loss of drug concentration may occur during this distribution phase due to many factors. Drugs in the circulation may become bound to plasma proteins. These plasma proteins are called albumin. And bound drugs cannot pass through tissue barriers. Only the free drug can pass through. Some drugs may also be absorbed into body fat and remain inactive for an undetermined amount of time until they move out of the fat back into the blood circulation. Drugs can also be prematurely eliminated through the first pass effect. Remember that the greater the blood flow to an organ, the greater the rate of distribution of that drug. The volume of distribution describes how widely a drug will distribute. Some drugs stay in the blood, some go from the blood to the extracellular fluid and won't go any further, and some drugs will go into the cells. The volume of distribution, or VD, is calculated by dividing the dose of the drug by the concentration of the drug in the plasma immediately after distribution. The V tells us that about the physiologic distribution of a drug. A low VD means that the drug's distribution is restricted to a particular compartment. A high VD indicates that the drug is concentrated intracellularly intracellularly with low concentration in the plasma. While in the bloodstream, drugs have the opportunity to exist in the free form or reversibly bound to the plasma protein. The extent of affinity of a drug for protein binding sites ranges from 10% to 99%. Highly protein-bound drugs have a low VD. Two drugs that bind to the same site on the protein compete for binding if they are present in the plasma simultaneously. One drug will displace the other drug from the site, elevating the free concentration of the displaced drug, which can cause toxic levels of the drug to build up. Plasma protein binding and drug availability are illustrated in Figure 2-8. After a drug is distributed to a tissue or organ and exerts its pharmacological action, it must be eliminated from the body. Elimination is the disappearance of the active drug from the bloodstream or body. Excretion is elimination through the kidneys and out of the body in the urine. Biotransformation. To be readily eliminated from the body, a drug must be in a water-soluble polar form. Thus, many drugs must be changed before elimination, and the liver is the primary site of drug biotransformation. After the drug is biotransformed, it is referred to as a metabolite. In other words, a lipid-soluble drug must become less lipophilic and more water-soluble or hydrophilic so that it is more easily eliminated by the kidneys. A prodrug is a drug that becomes active only after metabolism in the liver. Examples are levodopa, benazepril, and losartan. Some drugs are not metabolized in the liver and continue to be eliminated from the body unchanged. An example is lithium. There are two phases of metabolism or biotransformation. Phase 1 involves the cytochrome P50 liver enzymes. Phase 2, if the drug is not eliminated in phase 1, then the metabolite from phase 1 is conjugated or linked with highly water-soluble compounds to make it more water-soluble so that it can be excreted by the kidneys. Some drugs are inhibitors of the P450 enzymes. Therefore, they inhibit biotransformation or breakdown of certain drugs, which increases that drug's blood level and may cause toxicity. Elimination is measured with kinetics. After a drug is given orally, it will be absorbed by passive diffusion, and the blood levels attained will be proportional to the dose administered. In other words, the more drug is taken, the more drug will be found in the blood. As the drug is eliminated from the body, the concentration of the drug in the plasma will decrease equally over time in first-order kinetics. Most drugs follow first-order kinetics of elimination. Figure 2-10 is a graph demonstrating that the rate of drug elimination is equivalent to the concentration of the drug in the blood. In zero-order kinetics, elimination of a drug occurs at a constant rate and is not dependent upon its concentration. Figure 2-11 shows a graph that illustrates the constant elimination of the drug, and it is not related to the concentration of the drug in the blood. The definition of half-life, or T1/2, is the time that it takes for the concentration of the drug in the blood to fall to half of its original value. It is an indication of how long a drug will produce its effect in the body and defines the time interval between doses. It takes 4 to 5 half-lives for a drug to be considered eliminated from the body. Penicillin is given 4 times a day, but amoxicillin is given 3 times a day because amoxicillin has a longer half-life in the body, 1.3 hours, so it does not have to be administered as frequently as penicillin, which has a half-life of 30 minutes. The larger the half-life, the longer it takes for a drug to be eliminated from the body. The longer the half-life, the greater risk of toxicity if the elimination is interfered with. For example, a person with liver problems who does not have the necessary enzymes for biotransformation. This concludes Lecture 1, Pharmacology, Chapter 2.